What is Talquetamab and its mechanism of action?
Talquetamab is actually one of our new bispecific antibodies that goes after a different target. So far we've talked about BCMA, CAR Ts and BCMA bispecifics. But now in myeloma, we've actually found new targets, which is fantastic because we can attack those myeloma cells in a different way. So talquetamab actually goes after the antigen called GPRC5D. It's a whole alphabet soup. But this target is actually on myeloma cells almost 100%, especially those people who have had, treated myeloma. But we also see it sometimes in smoldering myeloma as well.
Talquetamab is a bispecific antibody that is expected to be FDA approved later this year. It is an antibody, a bispecific antibody to an antigen on the myeloma cell called GPRC5D, which is thought to be fairly specific to myeloma cells, but also has some expression on skin, nails, tongue, and low level expression possibly on other tissues. A bispecific antibody is an engineered antibody which has two hooks. One that recognizes an antigen on the target of interest, in this case, talquetamab GPRC5D, which is present on the myeloma cells. And then the other hook cuts onto the immune cell, the T cells, that are then brought into the proximity of the target to help kill the target. So, when we develop bispecific antibodies, or for that matter, CAR T and immune therapies to cancer, we're looking to have them directed towards certain molecules on the cancer cell. BCMA, or B cell maturation antigen, has been something that we've been talking about for a while now and have several approved therapies, CAR T cells and bispecifics too. So, GPRC5D is another molecule that we can develop anti cancer therapies directed to, and it is plausible and actually proven already in clinical trials that patients whose disease has broken through BCMA based treatments actually may respond to GPRC5D based therapies. And as I said, this has already been demonstrated in clinical trials.
Is GPRC5D on any other cells, and do we see any off-target effects?
Yeah, so GPRC5D is actually a great target in that it's not on any major the organs in our body, so that we worry that the bispecifics, when they're activating our T cells and bringing them into the myeloma cell and kind of putting it next to that, we don't want it to go to the other clinically relevant organs. And so the nice thing is that it's not on the heart or anywhere else. However, it is on hair follicles. And some of the side effects that we see are related to that.
What are the side effects on attacking GPRC5D?
Some of the side effects because of that GPRC5D being on hair follicles, it's not so much hair loss, but what we've seen is about a third of patients on the trial have gotten skin rashes. A few have gotten grade 3 skin rash, which means that you have to sort of hold the drug, wait till it gets better, and then restart. The good news is when they restart, patients don't have it anymore. They're able to figure out a way to keep that from happening. Another specific for GPRC5D we've seen toxicity is dyschezia, or taste changes. So there have been patients who aren't able to taste the same way. So that's been something new. For most patients, it's been relatively mild, but something that we're keeping an eye on. And then nails. So there's been some patients with a lot of nail changes. Again, nothing fatal or causes major morbidity, but again, something we're keeping a close eye on.
Are you managing any of these side effects?
Mostly it's been just supportive medications. So sometimes if it's really bad, you can do steroid creams, but usually it's things like antihistamines, things like that to see if it goes away. But there's not a single way yet that we've done, but most of the time it's just holding their drug if it's really bad and then bringing it back in after.
Is Talquetamab an off-the-shelf therapy?
The bispecifics in general, being off the shelf, is sort of, it's a biologic because it's still waking up your T cells to help kill the myeloma. But unlike CAR Ts, where you have to take the T cells out, put a new receptor in, grow them, and then give them back, this is off the shelf. I can order it and actually just infuse it like we do for other therapies in myeloma. So other monoclonal antibodies or drug conjugates. We're kind of getting back to those types of therapies where I don't have to wait 4 to 5 weeks to make something. And so the advantage there is that we don't have, if someone has really bad disease, we don't have to wait for a long period to actually start the treatment.
How is Talquetamab administered?
Talquetamab is actually sub-Q, which is fantastic, at least in our history. When we have patients who have sub-Q drugs, that takes less time for the most part. And for their study, it's not approved yet, but on their study, they've looked at two main doses that they think are probably they're gonna move forward with. One is a dose that's given every week, sub-Q, and that's for 3-week cycles. And then the other one is a higher dose of 800 milligrams that's given every 2 weeks for a 4-week cycle. And that's what they're trying to see, that can they give less therapy over time and still get maybe a higher dose, but still get the same response so that patients can get less drug.
Talquetamab is a drug that is administered subcutaneously. When it is available, that is the route of administration that will likely be approved. It is something that we do need to repeatedly administer, and so you start out with a low dose, and then you have to go through intermediate doses to get to the full dose. And once you're at the full dose, it is given either every week or every 2 weeks in clinical trials.
Is it a set dose treatment?
So it's a set dose, but there is something called priming that we do. And so basically, patients will get a really small dose initially, and they did it two different ways. So they get a small dose the first week, then a slightly larger dose, but still a very small dose, and then you get the full dose. So you can either get two priming doses or one, and that's really what they were studying. And for most of these studies, the two priming doses tends to work better, that we can get a higher dose of the drug in and get a better response and less toxicity.
Why do you do step-up dosing?
Priming and step-up dosing are similar. And basically, when you give something like a bispecific, if you give a lot at once, their T cells are just going to go crazy. They're going to have a party. They're going to, get activated, and they're going to start killing all that myeloma. And when that happens, you can get really high levels of cytokine release syndrome. So the fevers, the oxygenation that can go up and down, blood pressure issues that can happen. And it's because you have so much inflammation all at once. When you do the step-up dosing, you're doing a little bit at a time so that your T cells are slowly waking up. And then once they're already primed, then you give the bigger dose so they don't have as big of a party.
Are bispecific drugs still being done as inpatient?
Yeah, so I think for bispecifics, that the risk of CRS is still there. Thankfully, it's low grade, grade 1, 2, which we usually treat with just, acetaminophen, sometimes tocilizumab to help knock that CRS down. But because that's the highest risk is in the first cycle, all of these newer generation bispecifics against other antigens are also being administered in the hospital first. So the first dose of cycle 1 is usually about 48 to 72 hours in the hospital. And then once you don't have any more CRS, the rest is all outpatient.
What other side effects are you seeing with bispecific drugs?
Talquetamab CRS rates are about 70%, mid 70s. Again, mostly grade 1, a few grade 2, and I think only one grade 3. So fevers, that's the main thing that we see. There are some patients that had, a little bit of a drop in their blood pressure, so they needed fluids, and they had maybe a little bit of oxygen that they needed. So those are the patients that are grade 2, and that's usually when we use tocilizumab. So tocilizumab is an anti-IL-6 that we've used for lots of different things, and again, it works here because CRS is still similar in all these different products, and it's sort of a byproduct of these T cells getting activated and killing that myeloma. So we knock that cytokine down, IL-6, which helps kind of decrease all the inflammation. The other side effects, again, mostly are blood counts. So your white count, your hemoglobin, your platelets, they're not very severe, but we are monitoring them pretty closely after you've started. And then we might have to, usually we don't have to give transfusions, but again, if it gets really low, we hold the drug. But so far, people have done really, really well with it. And then the other ones that are specific really are the skin, nail, and taste changes.
With any bispecific antibody, the initial side effects that one is concerned about is cytokine release syndrome and neurological toxicity. We do see mainly grade 1, 2 cytokine release syndrome, which means that patients can be easily controlled, usually with drugs like steroids and tocilizumab. Very little grade 3, 4 toxicity is seen. The rates of neurological toxicity are also very modest and usually are not what requires any kind of intervention and usually self-limited, often concurring with the cytokine release syndrome. The other side effects, more long-term, are skin and nail changes because GPRC5D, the target, is expressed on skin and nails. So patients can have a rash, they can have their nails be brittle, and unfortunately, sometimes the nails fall off. Another side effect that is being seen is an entity called dysesthesia, which is somewhat a loss of taste, but more so the inability to swallow the solid foods because the antigen is present not on the taste receptors, but what we call the mechanoreceptors at the back of the tongue. Patients often feel that when they're chewing on food, they're chewing on cardboard and they can't swallow it. And that leads to often weight loss. The good thing is that quite a few patients, after a period of time, adjust to this side effect, and it is something that it appears that if you dose delay and dose reduce, can actually get around in most patients.
Is hypogamoglobulinemia a side effect?
So it's a little bit earlier for these studies, but hypogamoglobulinemia is something we see in a lot of treatments for relapse refractory myeloma, partly because a lot of therapies have already given patients that, and then you add another immunotherapy. And really, the hypogamoglobulinemia happens when we kill both the bad and the good plasma cells, so the myeloma cells plus the plasma cells. And these targets are also on good plasma cells. So again, there's definitely a risk for hypogamoglobulinemia, which puts you at a higher risk of infections. So, I think about a third of patients on this trial had infections, just like with a lot of other immune therapies. So it's just really important that if someone has a fever, that it could be CRS, it could be an infection. So this is why, we monitor and put people on antibiotics, make sure we work that up. And for hypogamoglobulinemia, if we need to give IVIG, most of our patients are getting that with pretty much all of these bispecifics.
Are low IgG levels being seen with Talquetamab?
So one of the good things about Talquetamab in comparison to BCMA-based bispecifics is the somewhat lower rate of infections that is being seen, and that is partly because actually the hypogamoglobulinemia is not usually as big a problem with this bispecific as it is with teclistamab and other bispecifics. It is felt that this may be because the GPRC5D is present mainly in malignant plasma cells compared to normal plasma cells. And paradoxically, in the patients who have responses, often what is seen is a rise in the immunoglobulin levels to normal ranges as the normal plasma cells are able to take over.
Are there any ways to manage the side effects?
For the skin changes, usually emollients, or if they're more severe, steroid creams can be given. For the nail changes, unfortunately, there's no good intervention that we know of at the moment.
Is Talquetamab currently used only as a monotherapy? Are there any pre-medications that people need to take?
So right now it's monotherapy. However, it's not FDA approved. So again, it'll be something that hopefully will get approved in the next couple of years. But I know that they're working on combination studies as well with daratumumab and other immune therapies. I think they used acetaminophen and diphenhydramine and then steroids, actually corticosteroids. However, with immune therapies, we know we don't want to do steroids for a long time because it can kill your T cells and your NK cells, the things we're trying to use to kill the myeloma. So for TAL, I think after the first cycle, they don't use the steroids anymore, but they continue with the acetaminophen and the diphenhydramine just to make sure you don't get infusion reactions, things like that.
So Talquetamab is currently before the FDA for approval as a monotherapy. The first few doses in clinical trials are being administered in an inpatient setting with pre-medication given during that hospitalization phase. The subsequent doses can be given outpatient. Again, though trials are looking at combination therapies, monotherapy is what will first be approved. The good thing about these is that after a period of time, no pre-medication in terms of steroids may be required, which is often a thing that patients do not like. However, certain level of pre-medication with Tylenol and Benadryl may still be needed beyond even the first several doses.
Who is the target trial population?
Currently, Talquetamab is being targeted for patients who have had 4 or more prior lines of therapy, which is for patients who have seen drugs of the class of immunomodulatory drugs, proteasome inhibitors, and CD38 antibodies.
Are there people with prior BCMA treatments?
On the trials that are before the FDA, there was a proportion of patients who had actually even had BCMA-based treatments in addition to proteasome inhibitors, immunomodulatory drugs, and monoclonal antibodies.
What responses are being seen in clinical trials?
So the responses in clinical trials with Talquetamab in patients who have had 4 or more prior lines of therapy, who are what we call triple class refractory, is about 60 to 65%, with about a third of patients entering a complete remission. And several of those patients in complete remission are actually in MRD negative complete remission.
Is there any information on the duration of responses?
The duration of response at the moment is not mature enough, but we know that several patients have been on the drug in excess of a year.
What data has been seen so far and who was eligible for the trial?
So the clinical trial for Talquetamab has been a phase 1/2, and mostly we've seen the phase 1 data. So they're trying to find the right dose. So they slowly go up on the dose. They're trying to find the right dose that doesn't cause too much toxicity, but has the best responses. And so far we've seen data for those first patients on the phase 1 trial, and both regimens. So the patients who got the lower dose of 405 milligrams once a week, as well as the ones who got the 805 every other week, have had great responses. So 66 to 70% basically in both groups. So pretty phenomenal. And patients who had BCMA therapy before were allowed to be on this trial. And they had about 25% or so of BCMA treated patients, which is fantastic to know that we have other antigens that we can go after. Most of these patients had had all other therapies already that they could either tolerate or, that we have for myeloma. So they were pretty relapsed refractory, multiple lines of therapy. Your ECOG performance status had to be good, 0 to 1, just to make sure you could get through CRS. But really no other major change in compared to other trials. I will say we think about penta-refractory patients as a big group of patients that have resistant disease. And this trial, I think, had about a third of their patients were penta-refractory.
Thanks for watching. By creating a HealthTree account, you can get exclusive access to the latest HealthTree University content, track your course progress, take quizzes, and bookmark lessons. Visit the links in the description below to get started.